This is a patient who has end-stage renal disease and is getting a pre-renal transplant CT. Had a CT 3, 4 years prior, and all the soft subcutaneous tissues, like findings were, I guess, a little bit there, but has certainly progressed over a course of 3, 4 years. And any thoughts on what you think this could be?
I have two differentials.
Yes,
Uremic arteriopathy versus calciphylaxis.
those are great differential diagnoses. So this patient ended up getting a biopsy because they had kind of a swollen, like the area that was like a lumpy, kind of a nodule that they felt. And so they ended up getting a biopsy by derm, and this turned out to be dermatomyositis.
Oh,
And the
wow.
patient was also diagnosed with Sjogren
Mm.
disease. So this is a kind of a systemic process, and that's why we see it, in kind of all around the subcutaneous tissues around the abdominal walls. But teach us about the calciphylaxis. Yashant.
Did we lose you? Sorry.
No, I'm here. Did you not hear
Okay.
me?
She wants
Yeah.
you to teach us about your differential.
Okay. So, I mean, I was about to say dermatomyositis when we see all these plaque-like calcifications or sheet-like calcifications. But since you said renal, so I thought like, probably that. But again, one more thing with calciphylaxis is like, the overlying skin gets ulcerated. So that's not the case here. But again, like, all of like even what the other differential that I said, uremic arteriopathy, it's not easy for us to differentiate on radiology. It will still look like what it looks like here.
Yeah. So just a quick summary from Copilot. So calciphylaxis is a rare serious condition characterized by calcification of small and medium-sized vessels in dermis and subcutaneous tissue, causes ischemia and necrosis, resulting in painful ulcers, like you said. And it's most commonly in patients with end-stage renal disease on dialysis or recent transplants. In contrast, dermatomyositis is an inflammatory condition, and they can also have muscle weakness. They get a distinctive skin rash. It affects muscles and blood vessels, and they get muscle degeneration and inflammation. Idiopathic, and it's felt to be like an autoimmune disorder, and the patient was diagnosed with Sjogren. So in their 40s to 60s, it's more common in females. They can get muscle weakness, purpley red rash, and then sometimes joint or lung inflammation.
Sure. One thing to remember with dermatomyositis is it can be associated with malignancy. It's also recognized as a paraneoplastic syndrome.
Didn't know that.
I have just one comment. This is awesome, this discussion. According to UpToDate, calciphylaxis and calcemic uremic arteriopathy are the same thing.
Oh, wow. Okay. Thank you for letting me know.
I didn't know that. I had never heard of this calcific uremic arterialopathy, but anyway, apparently it's the same thing. So
thank you.
Here's my second case. This is came for a kind of a second, third opinion on an InterStim that was placed elsewhere, and then this is what it looked like.
Within the rectum?
Yeah. So the discussion was really informative for me. So this was a pretty deep placement, and it's malpositioned in the rectum. What was informative for me was kind of the surgical approach to fix this.
wait, what did they try to place?
InterStim,
InterStim? What is that?
like a neurostimulator.
Oh, got it. Sacral stim. We got it. Oh, got it. I see now. Yep.
Yeah.
Why is there collection around the device, the battery?
Oh, maybe. Oh, that's a good question. Like maybe there's a hematoma or like, seroma or something. Looks like it's surrounding the wire. It was again a consult that came second, third opinion for this procedure that was done elsewhere. So what I learned was that the tips of the InterStim, it has a hook-like projection, so you can't just pull it out, because it'll create lots of tissue injury. And you wouldn't want to pull it out either because you don't want to translocate the bacteria along the tract, right? Then you'll get a fistula. So if the best approach to this probably would be cut it here in the subcutaneous tissue and then pull it out from below. And then do a clip overlying the, enterotomy.
Very interesting. It seems so long. Like, I don't even understand how it could possibly go that far, because usually it just goes straight into this. You know what I mean? Like,
Yes, yeah. They must not have used image guidance or something, because it was. I mean, I could see how the projection of it looks appropriate, but it was just too deep. It's like, right, and that's why they went into the rectum. So
interesting. Okay, so
Organized hematoma from no.
there's like stuff happening or in the tail of the pancreas and around the posteriorly, yeah, like
in the spleen.
on the spleen, and there's ischemia as well.
So you're saying ischemia because, like, you think these are
It's like
infarcts?
wedgie stuff or infiltration causing something. I don't know. It's
Yeah, and it's like continuous with this fluid here.
yeah.
All of this
And
kind of looks kind of like pancreatitis, right? Like, or could have been from like pseudocyst from pancreatitis.
yeah.
Yeah.
Okay. Any other thoughts?
Do you have the coronal?
Hmm?
The rest of the pancreas looks pretty good.
Is it hematoma which is liquefied? Like, was there injury, trauma?
Oh, sorry. I just pulled up the wrong coronal. Hold on 1 second. Okay. Sorry. This is the coronal. Okay. Yeah, it could be liquefying hematoma. There was no history of trauma.
There's ductal dilation in the tail only. Rest of the pancreas is all fine.
Okay.
There's like a lot of inflammatory changes around the stomach. No, you said no trauma, right?
No trauma.
And then that pancreatic cystic thing.
Yeah, what do you think about that?
Is it coming from stomach? Like, why are you showing stomach, and why this inflammation around stomach?
Yeah, there's like, going up to the esophageal hiatus.
Yeah, okay.
I don't
So
know if they're related or not.
we thought this was all from pancreatitis, and we got a kind of weird history. Like, there was a history of pancreatitis. We didn't have any prior imaging. I do think like the pancreatic tail there is a little dilated. And then I think like all of this seems reasonable for like sequela of pancreatitis. The question is this just a pseudocyst that's like related to all of this, in this person with this reported history of pancreatitis? And I can see how, like, you could think it could be a pseudocyst, but, it looks very, very round, well circumscribed. It's at the body tail junction. Long story short, they the whole time they presumed that this patient had pancreatitis, and these were all sequela of pancreatitis and pseudocysts, and their lipase had been elevated at some point. However, they resected this, and this turned out to be an MCN.
Wow.
Yeah. So I think in retrospect, I mean, if you didn't
So
see the rest
I'm
of it,
sorry,
right?
the MCN, is that related to the findings in the left upper quadrant?
I think the MCN basically caused pancreatitis.
Oh, and then that led to, yeah, I could see that.
Yes.
Like
Yeah.
maybe it
So
caused
this
ductal
stuff, and actually this
obstruction
stuff
and
came back.
perforated.
This stuff came back all pseudocysts. All of this stuff was pseudocysts. They did a distal pancreatectomy, splenectomy, and this came back MCN with low-grade dysplasia.
Okay. So then the duct, I'm sorry, is it because I was thinking like the duct perforated like at that tail right there, tail.
Exactly. Yeah.
And
I think
then
it
just like
obstructed the duct, and then that thing busted
decompressed
out and
into
caused
the left upper
pancreatitis.
quadrant. Yeah, I see.
Yeah. So I guess there's two lessons. One is you can have two things that are sort of related but unrelated, right? Like, so
Yeah.
the cystic neoplasm caused the pancreatitis. So you do have pseudocysts here, but they look different. Like, that guy looks different than this guy.
Yeah, I was thinking MC, and the rest of the pancreas looks good too.
Yeah, exactly.
Like it doesn't look like a patient with necrotizing pancreatitis or.
Yeah. And then the other thing, I've been tricked by this before, where like they'll say something like history of pancreatitis, and then you'll see this thing like this, and then you'll just kind of be like, oh, pseudocyst, right? So just don't jump straight to that conclusion, because it can be tricky. But when it's round like this, like you really, really want to see prior exam showing like a totally normal pancreas with like pancreatitis and then forming a pseudocyst over time. You don't want it to be like, oh, presumed pancreatitis because they had pain or something like that. And then, yeah, occasionally MCNs can cause pancreatitis. So this was just a tricky case with like where both was happening.
What led to the decision to do a distal pancreatectomy and splenectomy?
They weren't like feeling strong, like securely that this was a pseudocyst. And then there was a remote history of like some other imaging that showed a smaller cyst here. So they just said like, okay, let's go and take this out. And actually the cool thing is that all of this was just low grade dysplasia. There was no invasive cancer here, which I think that's reasonable since we don't really see a solid component or any septations.
Hmm.
They didn't EUS it?
They did not, no.
Okay. So this is a patient with this finding here.
Do they have
that's been
insulin
stable.
pump?
Yes. Well, they get insulin injection and
It's like the lipohypertrophy.
hypertrophy. Yes. Yeah. So they also call this like the pseudo breast sign. It looks like a breast tissue in the in the inter-abdominal wall at the site of insulin. So insulin stimulates lipohypertrophy and then can cause, and sometimes it can be symmetric if they inject on both sides of the subcutaneous tissue. So
yeah, it is interesting that it's
from
only in
insulin
that one
injection.
spot, because it seems like they probably switched their spot up a lot, but maybe it just the inflammation started getting incited in that one area and then just like it started a cascade.
So another elderly male patient comes with like lipohypertrophy because of insulin injection. Looks like lactating breast tissue.
Very nice.
Yeah, very extensive. Oh, you have the positive belt sign.
And the glucometer.
Yeah, continuous CGM.
Yeah, that's about it. Thank you.
This patient is a DCD liver transplant. So then all of these cases, we do MRCPs on them post-transplant. And so on the post-transplant MRCP, there was a biliary anastomotic stricture. So not ischemic cholangiopathy from DCD, more just anastomotic stricture. So patient also had elevated LFTs, white count, so signs of cholangitis. So they went ahead and did an ERCP, and then they got frank pus out of this. And then the MRI showed other findings as well. So there's kind of ductal enhancement, but there's also these areas of like geographic hypoenhancing region. Here's a diffusion. These all restrict with low ADC, corresponding low ADC.
PTLD.
Okay. Aarti, what do you think?
I want to see the venous.
Yes. So PTLD is a great thought. And here's the 5-minute venous.
I don't see the portal veins. So wait, hold on.
So here's the main, and then the left side is out.
Yeah.
The right side, you can kind of like see a little bit subtle, narrowed.
Can you show T2?
I guess I was wondering about like infiltrative HCC because it would seem to be going along the portal venous system. There's that's a lot of abnormal soft tissue in there. So I'm thinking some kind of like infiltrative tumor versus PTLD.
Because I said PTLD, you did not seem convinced. My other thought is because portal vein is gone. I don't know how long after portal vein was gone and this scan was done. So are these collaterals? Is this mass forming cholangiopathy because of cavernous transformation? Is it like enhancing slowly and steadily like fibrous tissue? Is it fibrous tissue? It is T2 dark.
Here, let me see if I can.
Well,
The
in
portal vein was
are you
okay
saying
before.
portal
Go ahead.
biliopathy from portal vein transformation, is that what you're saying? Like in that case, you would see flow voids and collateral vessels rather than like, although you can get some soft tissue. I don't think it would be, wait, this is at the same time frame?
This is post-transplant. So this is immediate post-transplant. The MRI that I showed you, it is like 3 months after transplant. So yeah, the portal vein is a little bit, the left is not really there. The right is maybe here, but there's, definitely narrowing here. This is post-op. You can see the surgical drain is still there.
That's wild that this is like immediate post-op. That's very weird.
Yeah. So, and then I'm gonna give you the
It must be some kind of ischemic thing then. Oh wait,
here's your
no.
PET.
Wait, did the
What?
like liver that was being transplanted in have some kind of malignancy? Like did it have already lymphoma or HCC?
Well, this was biopsied, and the answer is PTLD.
But the first scan what looked abnormal like was, or the immediate post-op scan had already started looking abnormal.
Yes. But and that's a great question, actually. Let's look through that. So there's definitely vascular complications. We start to see kind of abnormal geographic enhancing region, and then on the MR that's done, so there's multiple MRIs. This is the first month post-op right there. And
Yeah, I
then the
can see
MR
like, so basically on the immediate one, it wasn't really all the soft tissue obliterating fat.
correct.
And now you're getting a lot more soft tissue.
You've seen a lot more. So this is 2 months after transplant, and you can see there's progression of that. And then the
It
PET.
happened so fast.
Yeah, so it was within 3
crazy.
months of transplant, we start. So all of this, like you said, infiltrative process, obliterating, kind of progressive, so that was all. And then there's really high avid uptake. So the 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 patient did have frank pus when they did the ERCP for the biliary anastomotic stricture. So the question is, how do you distinguish cholangitis, infected cholangitis, from PTLD? So I think here, I mean, obviously FDG uptake. In addition to that, like you just lose the interface, like you lose all the fat in the hilum. There's mass forming process that is subtle, but it is there. That's been progressing over time, and kind of like having all of this mass effect. Any other pearls?
No, that's great job, Yashant. And I think it looks good for lymphoma, right? Like it's so infiltrative and like
Diffusion
obliterating
restricting.
planes, yeah. But that's crazy that happened so fast. But when you said how do you differentiate infection from PTLD, I think like MRI is, I mean, like it was so much more suspicious on this MRI, right? Like I think MRI is really helpful.
So there's a rare variant in which portal vein thrombosis and the cavernoma causes so much fibrous tissue. So that's called mass forming portal cholangiopathy, not commonly seen. So that's the imaging. It looks T2 really, really dark, but I think there won't be as much diffusion restriction. So I think, yeah, I was wrong on that.
I think Victoria showed a case here just like this. But yeah, that's an awesome case. And actually the soft tissue looks alarming there, but
wait, so I wanted to understand the soft tissue signal and the T2 coronal. Are these all just like really like small dilated, venous collaterals, or are these like fibrous reactive changes?
I think it's fibrous tissue. Yeah, fibrous tissue deposition.
Yeah, it's supposedly like the collaterals are also even in the CBD wall. And they cause like over time, they cause like inflammation and because they're like pulsating and stuff. And then it causes like a fibrous reaction. It's called like the pseudocholangiocarcinoma sign.
Okay.
Yeah, it says concomitant inflammatory and ischemic alterations cause peribiliary fibrosis.
I mean, if I saw this, you would still biopsy this though, right? Like, would you feel confident that this wouldn't warrant it? I mean, I know the diffusion is not suspicious, but it still looks pretty,
I
you know,
think, yeah, biopsy would still be warranted. Like, we can't
yeah,
be sure. Like,
right,
it's an interesting diagnosis academically, but on a clinical practice, yes, I
right.
would want to, yeah, agree.
You know what's interesting though, like this one is not a post-liver transplant patient. So like, I like, you know, bringing up PTLD for the other one, but here I guess we wouldn't bring up PTLD, but we'd probably just bring up lymphoma.
Yeah.
But yeah, I agree. Probably need to biopsy. Very cool. And this is Ananya's, Yashant, your colleague.
Yes, yes, yes.
That's awesome.
Yes.
Beautiful diagram too. Okay, so we can see that the bile ducts are a little dilated.
And there's like high intermediate signal right there,
Where?
left.
Left? Patients
go-
left?
Sorry, left like, oh, maybe that's just a duo. Never mind.
Yep, duo right there.
Right there, right there. Yeah.
So the bile duct is dilated, and then we go down into the head, and it looking a little sketchy in the head there. There's our dilated bile duct. So we always have to be like, okay, is there like a mass obstructing it? Pancreatic?
Yeah, there, right there. There's a mass right
Right
there.
there?
He has a ball. And then the duct stops there up to that level. Do you have the
Okay.
T1?
Wait, what do you think about this pancreatic duct though?
It actually multifocal abnormalities throughout the pancreas.
Uh-huh.
Is this your river?
Yes.
The Spanish River?
Yep.
Um,
The Gladiana sign. So you'll see. So like normally if that was really a mass, it should cause a double duct, right? But this
yeah,
pancreatic duct isn't dilated, but it kind of comes and goes. I think this
yeah.
is better on the coronal. So that's that like for Yashant, I don't know if you heard this, but there's a Spanish river that goes like both above and below ground. So like this is Ivan Pedrosa's sign for like when the pancreatic duct comes and goes.
Uh-huh.
And it's kind of like the sclerosing cholangitis variant of the pancreatic duct. So, and then the rest of the pancreas looks sausagey.
Okay.
Little pseudocapsule, like fibrous pseudocapsule here. So yeah, this was IgG4 or presumed IgG4 disease. They tested their serum IgG4 and it was not elevated, but it's only elevated in 2/3 of patients. And then they gave them steroids and the patient felt better. So they did not get any follow-up imaging, but they're doing much, much better. So
So it's isolated to the pancreas, so it looks like.
Yeah. And a couple of other pertinent things about, so I'm sorry. Yeah, you always have to go look at the kidneys. And you can see like the whole pancreas looks kind of abnormal. The kidneys, they were just like, yeah, there were some couple of like tiny cysts, but there weren't real lymphocytic infiltrates. And then you look for sclerosing cholangitis. And then sometimes if you don't get any of that, it's hard to get the diagnosis via biopsy because they have to get like big core biopsies. So often they'll just do steroids as like a steroid trial and see if they improve. A couple of the symptoms that these patients get is like this patient had jaundice, so painless jaundice. And then new onset diabetes is also another big one because you only need about 25% of your islet cells to make enough insulin. But because the like autoimmune pancreatitis is so infiltrative involving the entire gland, they often get will become diabetic, which this person did have. So yeah.
So autoimmune pancreatitis is basically 3 types. The type 1 is IgG4, which Shekhar just showed. So these are elderly men, and this is like, IgG4 related. Type 2 again looks the same, but it will be seen in young people like 20s or 30s, and that's most commonly associated with ulcerative colitis. And type 3 is ICI, immune checkpoint inhibitor associated, which I think you showed a case a couple of months back. And all these three can come as focal or diffuse enlargement of pancreas. And on imaging, we can't say which is what. Yes, demographics or the history may help, but ultimate thing lies with biopsy or maybe the serum markers. Thank you.
Awesome, thanks. So this person had an aborted cholecystectomy because they said that the gallbladder was heavily calcified and kind of tethered to the liver. And so then this is their post-op imaging. Was that aborted cholecystectomy was at an outside hospital. And you start back at the top. Oh yeah, incidental PE, by the way. Hopefully your AI doc picked it up.
What's happening in the liver?
What is that?
It's like a mass. There's like capsular retraction and not geographic kind of hypoenhancing, but it's irregular. There's all this fluid and
Okay, so I told you the history was aborted.
oh, cholecystectomy. Excuse me. Sorry.
Aborted cholecystectomy. Because it was like
So a laceration or something.
Heavily calcified, adhered to the liver.
Okay.
There's
And then
hydro.
there's obstruction. Yeah, the right hydro. What is that?
Fibroids? What is?
It doesn't look like fibroids. It doesn't look good.
I'll give you the sag. Do you think they're fibroids?
Abscess?
It's in the cul-de-sac. MR.
Okay.
I mean,
Okay, so you've said fibroids, you've said abscess, you said doesn't
it
look
could be like an ovarian mass.
Okay, good. Excellent. Okay.
And then the
So,
ascites can be from peritoneal carcinomatosis or post-op. I don't know if we have priors, but
okay, I'm gonna show you the MR. So here's the pelvis on the MR. Yeah, so here's your uterus with some fibroids, right?
Yeah,
And
where are
then
the ovaries?
basically these are the ovaries. So there's bilateral, large adnexal masses with extensive solid
like
components.
drop mets.
They can see much better on MRI.
Is it from what? Where is it coming from? The liver stuff?
Cancer.
Yeah.
Also, GB was cancer.
Yes.
Yeah, cholangio, yeah.
Yep. So I want to show you the CT again, but I'll just hold on. Let me just pull back the CT. So you said capsular retraction and then kind of like let it go. But if this was just perfusional stuff related to like an aborted,
oh no, this is not bueno. Yeah.
Yeah, it should not have capsular retraction, right?
It looks like cholangio.
You were saying even like infiltrative and all that stuff.
Yeah, and it's irregular looking.
Yeah. So the history was kind of a red herring. Like everyone's like, oh, it's just like postoperative changes from an aborted, like bad, gallbladder thing. But putting it together, like with these drop mets, we basically have like Krukenberg, like huge mets to the ovaries. We have this infiltrative mass in the liver, indistinguishable from this irregular gallbladder. So they ended up biopsying this, and this was adenocarcinoma of pancreatic biliary origin. So basically, it was like a gallbladder cancer spread directly into the liver, which it likes to do because it doesn't have like a good capsule, and the veins and lymphatics drain directly into the liver. It was causing that capsular retraction. And then it was causing, and then there's also actually all of these lymph nodes up here. And then it was causing ovarian mets too. So I just thought this was a good case, like, even though the history was leading you down one way, always, look at it and be like, if I just didn't even have the history, what would I call this, right? And this looks very suspicious. And then the pelvic stuff, I do think is tricky, and that's why MRI is so much better. But sorry, just to show you the gallbladder stuff here, right? That gallbladder is like indistinguishable from this infiltrative tumor here. And then all those lymph nodes. And then, yeah, I think that if you're not sure about the pelvic stuff, like always get an MRI. You can see things much better. And that was the case.
So this is an elderly man who comes with recurrent episodes of seminal vesiculitis since puberty, treated with antibiotics. So I'm showing you axial MR, T2. So basically, if we see that this
Yeah, is
medial,
the ureter inserting like abnormally into the
Ectopic, yeah.
prostate?
yeah, it's ectopic ureter inserting into the prostatic urethra. So that's the ureter. And the seminal, the vas difference is also ectopic. This medial thing is the vas difference, and it is inserting more laterally versus the vas difference on the right side inserts more medially where it is normally supposed to be inserting. Let me show you.
And those seminal vesicles look funny.
Dilated, yeah.
Yeah. Which, like, seminal vesicle abnormalities can go along with ureteral and renal abnormalities. I'm wondering, did they have like a Weigert-Meyer?
We don't know that because by the time we got the CT done, the kidney was already atrophic.
Reflux.
And that's the kidney, which was like
and it's also like
pelvic.
pelvic, yeah.
So I don't think we would be able to know that. Although I think the right seminal vesicle looks still okay. The left looks slightly more dilated. What do you think? Would you call the entire bilateral dilation?
No, it depends on if they've had like ejaculation recently or not, but that's what the normal limits if they haven't ejaculated.
And additionally, the patient also has like chronic prostatitis. So in the history, when I was reading, so they mentioned that, the chronic pain was because of recurrent seminal vesiculitis and chronic prostatitis. And eventually what they did was they took this left part of the seminal vesicle out and like took this part also out. Like so they removed the ectopic ureter from here.
Interesting, because that kidney looks so atrophic, like you wouldn't be making urine, but obviously like just, I don't know, there's some kind of static fluid that's causing recurrent infection.
Or maybe I guess some reflux, because ultimately this common channel in the prostatic urethra will still receive urine from the right system and can still reflux back.
Got it.
And I was reading that, ectopic ureter in males always inserts above the external sphincter, external urethral sphincter. So which means males will always be incontinent, versus in females, it can insert above or below. If it is below, the females will be incontinent. And it can insert, one of the commonest site in males is prostatic urethra.
Nice. Is that just air in the rectum? Why does it look so cylindrical?
So that's the probe. Like, previously we used
to... you put, this like, you guys don't still use it?
No, this is an old scan, I think, from like last decade. So
yes, we used to use a rectal probe for prostate cases as well, but we don't anymore.
Yeah.
Great case.
Okay. I've like time frame, 2 different scans, 6 months apart. And the patient has metastatic lung cancer. And focus on the liver.
That did show some
multifocal.
But at least the central lesion did show some nodular enhancement. Yeah.
Okay.
I would still want an MR.
Okay.
Because the other lesions don't. Yeah, like it doesn't. have classic hemangioma look?
Okay. So they said, indeterminate, and they did say this nodular stuff, maybe hemangioma, indeterminate, recommend MR. They didn't get an MR. Instead, they 6 months later came back and the lesion looked smaller. And then this guy looked a little bit smaller too.
Post-treatment change versus like the hemangioma getting sclerosed? I don't know.
So do you think this is a hemangioma?
It's not a definitive diagnosis. No.
Yeah. Oh, okay. You guys didn't fall for it, but we got the MR.
Oh, that
Oh,
doesn't
what?
look good. Yeah. No, like the T2 signal just a slice above looked a little bit
No, don't worry about this one.
there.
This is
Oh,
the
okay.
T2 signal.
Oh, okay, that
This
looks
is
okay.
too, right?
Okay.
So what do you think now?
Can we see the others? I mean, it looks like a hemangioma.
Yeah,
Like,
exactly.
like a.
Then this is the venous. Little bit of puddling, and then this is the delay.
Oh yeah, look at that.
Yeah.
Yeah.
So and then this one filled in. Awesome.
Mm-hmm.
So just a
And then sorry, on the T2, can you go back to the T2?
I'll even show you the spare since that one. Yeah, so this is the T2. And actually
That little
nice,
super
like,
bright area.
right
Yeah, the
area.
cystic area.
Yep.
Like I remember you telling us before, when you see that, then it's like you see that a lot with hemangiomas that have started to degenerate.
Exactly, especially giant hemangiomas, they'll have a brighter like hyaline degeneration centrally. But these are so well circumscribed, pretty bright, not as bright as CSF, but just kind of classic hemangiomas, and they fill in. So I just thought it was like a nice, like everyday example of like, stuff we see on CT all the time, and like, what are you going to say about it? One clue that you guys like, couldn't trick you guys, it looked like kind of nodular peripherally. So like, that makes you even think more about a hemangioma. And then one point I wanted to make, because, it was brought up like, oh, this is decreasing in size, therefore it must be a MET. Hemangiomas, I think they can look differently just based on the phase, right? Because you're not seeing the edges well. So like, it could be just filling in more on the other scan. So like, if you think it's a hemangioma and like, oh, now it's getting smaller, it doesn't mean it's not a hemangioma. You could just be like, not exactly viewing it in the same exact phase. Does that make sense?
Yes.
Yeah. So anyway, yeah, they didn't look like nice classic cysts, but it was the little nodular enhancement was a clue, and then confirmed with MRI that it is just a hemangioma.
This was defecating MR defecography that was performed elsewhere and submitted for interpretation. The patient has significant functional like defecation disorder, and the patient couldn't expel the balloon during the expulsion test, and also had like abnormal manometry. And then on MR defecography, like despite multiple attempts, like patient is not able to evacuate adequately. So here, let's go through all the phases. So here's the lift, and then here maybe it's supposed to the Valsalva, and then this is the final phase where they try to evacuate, and they're trying really hard, but they're not. It's not.
That's a beautiful example of urethral hypermobility. Do you see how
Oh yeah,
it becomes almost
here.
like horizontal? They can't urinate, and then that's a like nice anterior rectocele too.
It's a small one, yeah, a little small one, and it's yes, agree. So this patient meets the criteria for evacuation disorder. So there's diagnostic criteria. So they need to meet at least 2 of 3 tests to be diagnosed with evacuation disorder. Either they have an abnormal balloon expulsion test, like the patient couldn't expel the balloon. They have an impaired rectal evacuation by imaging, like we saw just now, or they have an abnormal anorectal evacuation pattern with manometry. So these are very difficult, challenging disorders to manage. This really impairs their quality of life as well. And typically the first line of treatment is pretty like extensive pelvic floor PT, physical therapy, and then extensive, like over 20 sessions sometimes, to help the patient kind of relearn how to, improve their evacuation and strengthen their pelvic floor muscles and help with control and coordination. Uh, and if they fail all of that, then the next is actually surgical consultation. And in kind of end stage disease where they've kind of failed all conservative therapy, uh, this often results in like a total colectomy with endometriostomy. So it's a pretty radical, operation to correct things. And these patients are like miserable oftentimes, especially after they've failed, intense physical therapy. So.
Yeah, I have actually quite a few friends who are in pelvic PT after giving birth.
Oh, wow.
To try to like kind of get the problem, like get sort of the pelvic musculature strong again, like as early as possible. Because actually, like I think like 50, like a lot of women, older women, especially after multiple births, will end up having a lot of pelvic floor issues. Nelly, do you know what this patient's risk factors were? Like, did they have multiple births or?
I don't recall, but the uterus looks normal for age, so I think they might be nulliparous.
Okay.
They're young, in their 30s, late
Oh, wow.
30s. Yeah.
Wow.
So this 16-year-old female comes with primary amenorrhea. Ultrasound is done, and sorry, my sin is not working. So uterus is absent. So any thoughts?
Oh, is it that like the three-letter acronym, the
Meyer
female
Kuchen's
equivalent?
Kushner-Hauser syndrome.
That's exactly right.
Well, so it could be Mullerian agenesis, or it could be like there's some kind of ambiguous gender thing. Like, did they do
Do they have
chromosomal
testicles?
analysis? Like, are they truly female?
That's a very good thought. So let's see what the adnexa shows. So we are showing the right adnexa right now. So this is longitudinal and this is transverse. So we see this structure in the right adnexa. Left adnexa, similar structure. No hint of like follicle, right? I mean, these are hypoechoic.
Maybe you get the undescended testicles.
Perfect. Yeah, these are undescended testicles. So what are your thoughts now? What this could be? Primary amenorrhea, no uterus.
They have that like, what is it, the 5 aromatase or something like insensitivity, like where they're
Androgen
testosterone.
insensitivity syndrome. Yes.
Yeah, androgen receptor insensitivity syndrome.
Yes. Perfect. So these are undescended testes, but the question is, what are these hypoechoic nodules that you see in the testes?
Well, I mean, pelvic testicles are at increased risk for developing testicular malignancies.
Could it also be like adrenal rest?
That's again a very good thought. So MR is done. And if you
It's
see,
bilateral,
yeah,
multifocal.
let me show you sagittal. So these are actually Sertoli cell adenomas, which are T2 hypointense and which are characteristic of undescended testes in complete androgen insensitivity syndrome. Additional findings would be cysts, paratesticular cysts, which can also be seen. And I think I found a paper from radiology on the same. Let me share that.
That's an amazing case.
Mm-hmm.
Wait, is the androgen insensitivity associated with undescended testes? Like that often happens together?
They
So,
can.
yes.
Okay.
Sorry, go ahead. So
No, go ahead.
Sorry.
No, they don't descend normally, because they're not. Yeah.
Okay.
Like I mean, they have very high levels of testosterone, but they're not responding.
Got it.
So they can present with primary amenorrhea, or they can present with undescended testes. They can, and those testes would be either intra-abdominal or in the inguinal region. So that's the paper I was referring to, that's the paper I was referring to from 2013. And they talk about a couple of things which I showed. So Sertoli cell adenomas and paratesticular cysts. And they did study quite a few. And interestingly, their study showed that Sertoli cell adenomas are present in as high as 83% cases. And I was reading pathology literature and they said 24%. So like depending on the series, so the numbers can be as low as 23 to 80 something percent can have these. And yes, this paper also concluded that MR cannot tell that if the Sertoli cell adenoma is getting degenerated into malignancy, like the malignant variant. So regardless, the treatment of choice is prophylactic gonadectomy after puberty is attained. And MR can still be done just to see if something major is going wrong or not, but MR cannot differentiate between the benign and the malignant tumors.
It's amazing they had so many cases, but I was just thinking like, because, you know, I haven't seen this that much, but it must present in adolescence. So I wonder if our pediatric colleagues see this more.
I think so, yeah. The pediatric people would see this more.
Cool. Well, you had a great case.
Thank you.